Before we hear from this afternoon's speakers, we thought it'd be interesting to lay some groundwork, lessons and inspirations from the history of our field. In the pressure of the moment that COVID has presented us with, it's easy to assume that this is a unique event requiring unique solutions. And in many ways it is. But also perhaps we should build upon some of the learnings of the past. So please bear with me. The new stuff is coming up after my presentation, but I hope this backdrop will help us imagine what observers will say about our response to COVID-19 20 years from now. So we can look back, I reckon, about 4,500 years for evidence of activities involving assistive technology. So what were the drivers of that intervention over that time? And what were some of the things that affected adoption? So I think these are all important things for the work we do to really have an effect, to have an impact. So if you look back, you can find references to prosthesis that go back to 3000 BC. And if you look at the bottom picture of that wooden big toe, it's really interesting to look carefully at how they built the articulations into this. This was not just a cosmetic development, but was actually quite functional and thoughtful and engineered back 3,000 years ago for a priest's daughter who lost a toe. And there's a prosthetic socket that doesn't look so different from the kinds of prosthetic sockets that we produce today. Well, that's understandable because the shape of the residual limb hasn't really changed over that time period. Just want to play you this quick video. Hopefully you can hear the audio okay.
All historical prosthetics is the iron hand of Gert von Berlichingen, a 16th century German knight who remained a German folk hero well into the 20th century. He actually said that he could wield a stronger blade than the artificial blade.
Martin, sorry to interject. Would you mind sharing the sound of the computer where you press?
I thought I had. Okay.
Press share. It's just a little low.
Yeah, I thought I had got that activated. Let me just see. Why not? Don't want to do something dramatic like leaving the meeting. Well, let me tell you rather than hold things up, because this is the only audio that we're going to be dealing with. If we can keep this moving forward. So what this prosthetic is a prosthesis that was developed back in the 15th century for a German knight. And at that time, there was an enormous amount of what you might describe as privateering of soldiers who would actually make soldiering a living and going out to war. And he lost a limb, and then the armorers created this, this prosthesis, upper extremity prosthesis. And you can see the functioning of the prosthesis, both in terms of the articulations, but also the ability to activate them with buttons on the side. He claimed that he could use this prosthesis and achieve as much control and strength in managing his shield and his sword as he could if he were just using his normal limb. And we've heard those same stories in Paralympic conversations, for example, in more recent times. So we must remember, I think, as we go forward, the sophistication of the work that was done historically, and bear that in mind in positioning the work that we do today. But if we think about what some of the inspirations were for the assistive technologies that we use today and we've seen developed, war is one of the factors that has driven that. So thinking back to World War I, then the introduction during World War II of penicillin and how that enabled people to survive very traumatic injuries. And this resulted in the demand for assistive technology and other solutions and advances in rehabilitation. Then more recently, when we look at in the Vietnam War, the consequences of both physical and mental injury and the consequences afterwards of social impact. And then after the Falklands War in the UK, the advances for management of burns, And then more recently, again, in Afghanistan and Baghdad and Iraq, how we've seen the push to understand PTSD and other mental health issues associated with conflict. So in each of these cases, we've seen advances and changes occur in the field of rehabilitation that have essentially been driven by war, but also pandemics. So here we are in one. This is not the only one. So going back to the pandemic of the so-called Spanish flu, here you can see some examples from Canada of the measures that were taken back then. How familiar is this picture to us today? One of the interesting differences between COVID flu from the 1918 period and others, such as polio, is the effect that that had afterwards on the people that sustained the infection. So with polio in 1952, for example, in the United States, there were 57,879 polio cases and 3,145 deaths, predominantly among young people and children. And of course, the challenge with polio is the residual disability that occurs afterwards. Here again, look at these polio precautions and how similar the advice is that was given back then in the 50s to the advice that we're now giving today. They closed the swimming pools. I remember some of this because I was just a kid at the time that this was happening, and there was no polio vaccine when I was a little kid. And so you felt this threat, just as we feel that same threat today. But you look at the profound disability that resulted afterwards. Here you've got, for example, FDR, who sustained disability associated with polio. But look at the respirators that had to be used in order to support those people that sustained a pulmonary consequence of paralysis associated with polio. And one person that I know of, not personally, but I've been researching, lived for 64 years in one of these iron lung respirators. And you look at the impact that that had on young people. Imagine the mental health challenges it represents to spend prolonged periods of time in an iron lung like this. And then thalidomide in 1961. I was interested to know, to me, I remember this well, but in talking to some of the folks in my lab, they hadn't really heard of it. And thalidomide in 1961 resulted in 24,000 malformations and 123,000 stillbirths. And it resulted in essentially a loss of particularly extremity growth during the development of the fetus. And this was a result of a drug that was introduced to manage morning sickness during pregnancy. And created this large number of people with profound disabilities, which became one of the driving forces outside of war that resulted in many of the advances that we saw during the 60s, 70s, and 80s relating to assistive technologies. But let's think of some of the other factors that come into bear that have changed so dramatically, even in my lifetime. And one of those is the marginalizing attitudes towards people with disabilities. And I would argue that those marginalizing attitudes were prevalent through to the 1990s, and in some cases are still there today. But do I have evidence for that? Yes, I do. Look at on the right-hand side, that authorized visitor badge stands for the Royal Hospital for the Home of the Incurables. And this is in Putney, London. And this naming of that hospital actually changed in 1988 and again in 1993. And so this was representative of how we saw people with disabilities, even in relatively recent history. And looking here, Toronto, a similar name for their hospital. So this was just not an isolated case. So one of the things we've seen is a dramatic change in the way we view people with disabilities. Again, looking at FDR, we can see that what he did was get out of his wheelchair and try to look as able-bodied as possible when he was at this summit meeting with Churchill and Stalin at the end of World War II. And so that was a requirement for him to be empowered as a politician because of the disempowering effect that disability had on the perceptions of people in society in relation to him. And we've seen major changes occur in recent history in relation to that. And some of the people that were responsible for those changes in the foundations of rehabilitation as we know it today included Howard Rusk and Henry Kessler, both of whom produced really renowned rehabilitation institutes in New York and New Jersey. And the famous book by Kessler, The Knife is Not Enough, represents a very important transformation that occurred during the latter stages of World War II and the early 1950s. And that was to start to view the person as a whole person and not to view them as a disease or a diagnosis or a loss of something. And so they were the founders of that kind of thinking and were able to put that into practice in the ways that rehabilitation was delivered. Now, on the left-hand side, you can see Sir Ludwig Guttmann, and on the right-hand side, our own Robert Stedwig. Sir Ludwig actually was my external examiner for my PhD, and Bob Stedwig is a good friend of mine. Why are these two people important? Because they helped to make that transformation in the way we view people with disabilities through what they did in establishing the Paralympic Games and the International Paralympic Commission, and enabling people to be presented to society as capable of remarkable athletic performances. Look back now to what those first Olympic Games looked like. Large numbers of people in wheelchairs, and very conventional looking wheelchairs at that. The introduction by Guttmann, for example, of archery changed people's opinions of what rehab was. Rehab back then was very much what you might describe as classical physical therapy, on a couch, achieving range of motion. And what Guttmann said was, let's change our way of thinking about this and let's place rehabilitation in a functional context. And now we look at the sorts of remarkable things that happen during the Paralympic Games and the kinds of technology people are using. You can see how that work that was established then has influenced the design and development of modern day prosthetics, modern day wheelchairs, and modern day other assistive devices. This leads us to thinking about this framework, the ICF framework, that causes us to think not about the person as a disease, which is what the International Classification of Diseases causes us to do, but think about this person in a more balanced way, thinking about their participation and the ability of that person to perform activities that are related to their priorities, and how we can adjust things like environmental factors to enable that person to achieve their goals, rather than put all of the weight on that person achieving their goals through somehow managing their disability. It becomes a partnership between society and the person with a disability. But other things also happen, such as social activism. And for example, after the Vietnam War, people with disabilities and other people who were just coming back from Vietnam were isolated, socially ostracized, forgotten. And there were many reasons for that relating to people's views about the Vietnam War. It also resulted in large numbers of destitute people who were veterans with disabilities, and that somehow or other society just turned their back, looked the other side. And that we've now seen such a transformation in doing that. So now look at the bottom left, and you can see the Glen Rose Karen system that we're using through Highmark to enable people with PTSD to address some of the triggers that affect their quality of life associated with PTSD by using virtual reality to recreate some of those triggers and address them. And then also some of the advances in technology that occurred, especially in relation to injuries that occurred during Iraq and the Afghanistan war, for example, at the Walter Reed Hospital, which I visited, and I can't tell you what an inspiring experience it was to see the rehabilitation programs and attitudes that were in such contrast to those that occurred after Vietnam. And so also the disability rights movement became powerful, and that resulted in the Americans with Disability Act. Now, of course, when you listen to my talk, you'll realize that the timelines are all muddled up, because that's the way things were. Things didn't happen in a nice, tidy, linear sequence. They happened in a complex and chaotic way. But these different segments all came to bear on what we now see in terms of the opportunities we have for using technology to support people with disabilities. But the social justice, the advocacy, the going out there and getting recognition, the values that we associate with disabled people who are members of our society are all part of the big picture of how we develop and deliver assistive technologies. And don't forget the demographics. Here we're seeing another factor that's coming to bear that's also incredibly important in context of COVID-19, and that is the demographics, that rapidly aging population, that top heaviness in society of older people relative to younger people that are able to care for them. And COVID has really brought that out, as we've seen in the last year. Also, another driver of assistive technologies has been what I would describe as dual use technologies. So what we found is that some of the advances that we've been able to apply in the field of assistive technology have been driven by other political priorities, such as the space race. And during the 1980s, Reagan had a focus on the Strategic Defense Initiative, or the Star Wars Initiative. And they explicitly said that we're going to be developing a space-based defense system, but we're going to also provide funding to support disability and other related benefits to society. And the political imperative to get this legislation through was built on the fact that it was a dual use concept. And now, of course, DARPA, and Vivian is very much involved in this, is looking at those similar dual use opportunities for defense and disability applications. So there's the power of celebrity. So the famous Christopher Reeve situation where Superman experienced a severe spinal cord injury, a high-level spinal cord injury as a result of a horse riding accident, and created the Christopher Reeve Foundation, where the claim was made in 10 years, we're going to solve the problem of spinal cord injury. And that created an impetus for the focus on looking at curative approach to spinal cord injury. And the Miami project that started off originally with that same type of goal. And interestingly, as many of you know, Christopher Reeve ultimately died of the consequences of a pressure ulcer. And then Helen Hayes, who I knew when I was at Helen Hayes Hospital in New York, the first lady of the American theater, was passionate about advancing the field of rehabilitation. And one of the things that evolved out of Helen Hayes' involvement with the hospital I worked in was the Helen Hayes Hospital Marathon. And this was one of the first marathons where people who were wheelchair users and had other disabilities all competed together in the same race. This we now take for granted. But previous to this, they had their own race, a separate race from the able-bodied athletes, a change in attitude. Helen Hayes' daughter died of polio. So when we think of enabling technologies, I think of these people. These are the people I think of who I encountered during my career, who I would argue were some of the most visionary people in moving the field of assistive technology forward. Heinz Wolf, known as the Mad Professor, remarkable person in looking at technologies that would be used to support seniors, and created this term I love, which is the term of metastable elders, the idea of a pencil standing on its point and a little thing that nudges it and it falls over. That represents a certain segment of seniors in our community. The fascinating thing, and I only realized this last night when I put this together, is how much influence Canada has had on the assistive technology field. Here we've got Mickey Milner, Ontario Crippled Children's Hospital, as it was known then. We've got Al Cook, former Dean of the Faculty of Rehab Medicine, Jeff Fernie, over there now in the Toronto Rehab Institute, Colin McLaurin, who started off in Ontario and then went to University of Virginia. The only outlier is Jim Reswick, who is from California, and what can I say? And Doug Hobson, also from Canada. All of those people, I would argue, were the most influential people in defining assistive technology as we know it today, and nearly all of them are Canadian. So what happened? Well, what happened was all of them went somewhere else except Mickey Milner. And why did they do that? Because of funding. The United States during the 1970s and then later on into the 1980s created what they called the rehab engineering centers, And they put large amounts of money into creating those centers that then created assistive technologies as we know them. I bought into that model. So I developed all sorts of fancy technologies like this one, which is a FES rowing machine with an impact capability intended to improve disuse osteoporosis by creating an osteogenic impact. Complicated machine, lots of fun as an engineer. But what I noticed was something that was changing, and that was these technologies were going commercial. And what you could now do is you could go out and buy them. And this was a major improvement over those rehab engineering centers, because the problem with the rehab engineering centers was they were delivering services, but you had to have an engineer around in order to manage all this technology and make sure it worked. It was not a sustainable model. What we needed was commercial products that had got the manufacturer behind them, that made sure they were robust, that clinicians and patients could use. And so I recognized that there was this change going on at that time, and I rebelled. And I actually created quite a lot of difficulty with those guys in that previous slide. And we created what was called the Center for Rehabilitation Technology at Helen Hayes Hospital. And it's still there and it's still operating. And the purpose behind this was to use those available technologies and to deploy clinicians and enable clinicians to learn how to use those technologies effectively in the delivery of advanced assistive technology services to people with disabilities. This is my group. As I left New York, what do we notice about my group compared to those guys that I showed you in that previous slide? There are a lot less guys. It's a much more gender balanced group of people. And a lot of them are sitting on the ground. We were a flat organization. We were not a hierarchical engineer at the top, clinician at the bottom kind of model in terms of the way we were delivering assistive technology. But we were an interdisciplinary team that was designed to pull together in order to deliver exceptional services to people with disabilities. So here we are now in 2021. What an interesting time to be in that we got all of these things intersecting at the same time. Our pandemic, our economic meltdown, massive changes in our healthcare system, social activism, technological innovation, and socio-demographic pressures all coming together at the same time. And then there's the environment. So let's not forget it. And let's not forget how important some of the things we do can be in helping to support our environment going forward. So finally, this is what I think it's about. It's trying to achieve equity. It's making that transition from that technology that's designed for a person with a disability and applying the ICF framework to try and achieve something that is more like the right-hand side. But I'm still excited by the technology. I'm still excited by yesterday's event with landing Perseverance on Mars and the former rover called Opportunity. These are key words for us going forward: opportunity, perseverance, and impact. And impact, that happens to be the endurance crater on Mars that the Opportunity rover went to. So these three words, I think, can be words of inspiration for us going forward as we tackle COVID and as we think about my opening question, which was, what will people say about us 20 years from now in terms of the way we went about supporting people with disabilities during the COVID era? Thank you, Marty. That's about all I have to say at this point.
Great. Thank you so much. Thanks for this very interesting historical perspective. And it was a great start for the Mini-Symposium. So we have about a minute for any question that people may have. You can type your question into the chat box, either publicly or just send it to me. Or if you would like, you can unmute yourself and ask a question. I definitely have questions, but I'd like to give time to others for their questions. So maybe, Martin, while we wait for others to type their questions, what do you think about what COVID will do? What's your prediction about what COVID will do as far as the, acting as a catalyst for development of new assistive and rehabilitation technologies. Is there any particular sector of the patients or individuals with seniors that COVID will target and will prioritize technology development for going forward? The same way, I could imagine that, for instance, wars resulted in development of technology for people who had lost a limb.
Yeah, I think the way I'm looking at it, Maddie, is that I'm hopeful that COVID will be going away rapidly over the next year, and that thankfully, as far as we know right now, the physical consequences of COVID may not be as severe as some of those other pandemics, like the polio, and maybe, if you call it a pandemic, the consequences of thalidomide. And so I don't think we're necessarily going to be left with a large residual number of people with disabilities that we need to address. I may be wrong, but the way I'm thinking is it's an opportunity for us to change the way we do business. And this is a lot about what we're talking about today in terms of the virtual health discussion. But I think what we need to do is we need to think about virtual health from the standpoint of what is going to be the quality experience a patient has in the future when they have a virtual health assessment. And that means that we need to establish some standards, some practice guidelines, some clear objectives, and some good evidence to show when and when not to use, and how not to use various different technologies and different approaches when we're delivering virtual health technology, virtual health assessments, such as rehabilitation assessments. One thing I would add to that, and I think that it's very important, and it was in yesterday's Harvard Business Review, one of the difficulties the US healthcare system has is the focus on technology innovation and the neglect of process innovation. We must not fall into that trap going forward. As we use these new technologies, we must bring process alongside technology to make sure they're being used effectively, properly, and the good technologies don't fall by the wayside because of them not being integrated into a clinical environment in an appropriate manner.
Okay, great. Thank you so much. There is one question that I'd like to ask on behalf of the person who typed it. Could you comment on accidents on rehab thinking?
Yes, it's a really interesting point. One of the things, we could have put it in if we had more time, was the impact of seatbelts on disability, people acquiring disabilities, and then headrests, of course. There was a dramatic change in the number of people that sustained head injuries and spinal cord injuries associated with the introduction of seatbelts and headrests. And so what we've seen over the years is the improvement in accident prevention through motor vehicle design and other systems design that have actually reduced the incidence and prevalence of disability quite dramatically in society. So go back to the 60s and 50s, drunk driving, there were no alcohol limitations really to speak of back in those times. Then the seatbelt and other safety provisions such as, airbags and so on. And you're talking about back then, a very high prevalence of spinal cord injuries compared to what we experience today. Oh, Marty, you're on.
Yes, thank you so much, Martin. I just wanted to